Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah, alhamdulillah, wa sallallahu ala rasulullah sallallahu alayhi wa sallam. Today we are going to discuss CKD-related anemia and new approaches for management. We are delighted to be sponsored by Astellas Farmers, which promotes this educational activity. By the way, this educational is pure educational activity, has no relation to any pharmaceutical product. And these are my disclosures. And these are the talk outline. We are going to address the anemia and its magnitude in CKD patients with the multifactorial effects of anemia, the target hemoglobin level in our population, and the ups and downs in the last decade, and the current guidelines for management of anemia, pointing to some anemia players in the field of managing those patients. As you all know, anemia is a complex situation in chronic kidney disease patients. It's not simply decreased erythropoietin production as per the interstitial cells in the interstitium of the kidney. It's much more than this. It is erythropoietin hyporesponsiveness and resistance mediated by inflammation, infection, or functional or absolute iron deficiency. All these can cause hyporesponsiveness or aporesistance. Definitely hyperparathyroidism can add to this as well. And blood loss, whether from the dialysis in dialysis patient or from the gastrointestinal tract or from the repeated phlebotomy due to multiple venous sampling for those patients for analysis and so forth, and definitely other causes as well, anemia of chronic illness and uremic toxins and uremic solutes that are retained and even in dialysis patients, not all of them are cleared. All these add to the magnitude of anemia of dialysis patients. Hence, it's a very complex situation. And that's why just replenishing erythropoietin by EPO or ACEs did not prove successful in 100% of patients to restore anemia. And as you know, according to the WHO, 30% of the world's population having anemia. If you go for cancer patients, this number increases to 50%. In dialysis patients, it's almost 90%. So it's 9 out of 10 patients on hemodialysis suffering from anemia, which is a big issue that needs to be always taken in consideration. In Egypt, the situation is even more drastic. More than 85% of our patients are out of the range, meaning they are less than 11 grams, very, very few more than 12 grams, and almost like 10% only are in the adjusted range of 11 to 12. But most of our patients are less than 11 grams per deciliter, and even more worse, that almost 70% of them are less than 9 grams per deciliter, which is considered to be a significant stage of anemia for those patients. And although this data is like 2 decades ago, but the data did not differ a lot in our dialysis population as per the latest registry from the ESNT, but yet this is not published. And the anemia, together with CKD and cardiovascular disease, is a deadly triangle. As you can see, CKD perpetuates cardiovascular disease through accelerated atherosclerosis and accelerated heart failure. And CKD causes anemia, and anemia perpetuates the cardiovascular disease, specifically the heart failure and the coronary artery disease again. And you can find these many players in the process of CKD, anemia, and cardiovascular illness, starting from erythropoietin deficiency, anemia of chronic illness, the inflammatory and malnutrition milieu, the LVH, and the mortality, morbidity, and definitely the coronary artery disease and the complication of interventions that would all lead to all-cause mortality and decreasing survival in those patients. So what's the story of target hemoglobin level? There's a paradox in the target hemoglobin level that have been shown for many times in the patients with anemia. As you all know, registry data showed that morbidity and mortality in the dialysis population is lowest at higher hemoglobin level. In the meantime, the randomized control trials persistently showed that higher hemoglobin level are associated with increased morbidity and mortality, specifically for cardiac events with strokes and MI and maybe even arteriovenous and graft thrombosis. So although you need to increase the hemoglobin to have better quality of life and maybe from the registry to decrease morbidity and mortality. When RCTs have been conducted, they almost in all trials showed that this was not true. Here, starting from the very old normalized hematocrit study, create, coir, and treat with different agents, there is only one primary outcome. There is negative survival with increasing hemoglobin. Primary endpoint was death from MI, time to major adverse cardiovascular event, death and MI again, and hospitalization, and congestive heart failure, death, cardiovascular death, and end-stage renal disease. They were all negative in the primary outcome. Even there was more concern that there is more thrombosis or more major adverse cardiovascular events and hypertension or more CVS and even malignancy. So there is no better survival and there is increased worse outcome and prognosis with correction of hemoglobin above the target of 11, here 14, 13, 13.5, and 13, all proven bad. That's why the guidelines have been moving through years, and maybe the most consistent guidelines throughout years from the late 90s till this time was the British guidelines. The UK NICE guidelines is always more conservative, having hemoglobin down to 10.5, which suits our situation in Egypt as well. We have been always concerned about increasing the target hemoglobin above 10 in Egypt, and this was even published in our latest guidelines maybe a couple of years ago in the ESNT Egyptian anemia guidelines as well. So currently the KDIGO guidelines at last 10.5 to 11.5 gram per deciliter. This is the target hemoglobin, and definitely not intentionally more than 13 gram per deciliter. And this is an important issue because not intentionally mean that if your patient goes beyond the limit of 11.5 with no complications observed and no intention to increase the dose of EPO or ESAs to reach this target, this can be allowed. And this is an important issue actually because this target was driven by the ESA treatment and the complications that occurred with higher doses of ESA treatment that necessitates going down with the target below the normal level for normal population. So the target now at initiation, if a patient is CKD non-dialysis, is a hemoglobin less than 10, your target and maintenance would be at 11.5. If it's a 5D, that's to say stage 5 on dialysis, and your 9 to 10, avoid drops below 9, and 9 to 10 is accepted per KDIGO, whereas with the European renal best practice guidelines, don't allow to fall below 10, and the maintenance should be between 10 and 12. And with the Keraie or the Canadian Society, again, don't allow to go below 10, and the target is 10 to 11, and is again accepted between 9.5 to 11.5. The KDUKI, not the KDIGO, the KDUKI, the American NKF one was 9 to 10 again, and avoid going below 9, and the maintenance should be below 11. In the British guidelines, the target is below, the initiation of ESA should be when the hemoglobin is below 10, and the target for the maintenance is 10 to 12 again. So to sum it up, when your hemoglobin drops below 10 or 9 in the more conservative groups, start ESA. And you target to maintain your hemoglobin by ESA between 10 to 11, maybe 10.5 or 9.5 to 11.5. Don't target more than this by increasing doses of ESA. So what the current guidelines states for managing and treating and assessing anemia in our patients. First, dosing of ESAs. As you know, there is a short-acting and the intermediate or the dapapoetin and the Sierra. and the pig anisidide, which is not anymore now in action. For the short acting, the half-life, if you give it intravenous 6 to 8, subcutaneous is longer, up to 24 hours, and the frequency of administration would be once to thrice weekly. And definitely the subcutaneous is more effective than the IV, and you would need a lower dose when you go for the subcutaneous route. Earlier on, it was suggested that the subcutaneous route is associated with the PRCA or the pure red cell aplasia, although this issue is questionable now. The darbepoetin alpha, again, it can be used for a longer duration, and it can be given from once weekly to once monthly. Subcutaneous and intravenous are equal. And the Sierra is even more prolonged in action. The frequency of administration, again, can be once every 2 weeks to once a month. And this is the KDIGO guidelines. Again, the hemoglobin below 10 start the ESA, although this should be individualized based on the rate of hemoglobin fall, the response to iron therapy, the risk of transfusion, for example, if the patient is indicated or planning for transplantation or not, and the ESA-related risk and the symptoms of anemia. So it's not one size fits all, it's individualization according to the comorbid condition with the patient. For a patient on dialysis, and ESA therapy should be used to avoid hemoglobin drops below 9 grams, and start if the hemoglobin between 9 and 10. Again, individualization of therapy is reasonable for the quality of life. For example, if you're having a young chap of 25 to 30 years who is end stage on dialysis and he's still going throughout his life and his work and his daily activity, you would target even a higher hemoglobin level than in the guideline to have a better quality of life with continuous monitoring of any related complication. And definitely you should be very much careful in case of hypercoagulable states with patients with repeated vascular failure or vascular access failure. IV or subcutaneous are okay with the hemodialysis patient because you have the route already there, but in the non-dialysis, subcutaneous is preferred, and the frequency is based on the CKD stage and the setting of the treatment, and definitely the type of ESA, whether it is short or long-acting ESA, and the rate of increase in the hemoglobin. So we've all managed patients who received ESAs and did not respond in the appropriate dose. And in few situations, you might go to a higher level, higher doses of ESA with still poor response. There are 4 common causes for ESA resistance. Iron deficiency on top. And again, iron deficiency could be either functional iron deficiency or actual iron deficiency, absolute iron deficiency. And as you know, we monitor the iron deficiency in our patient by transferrin saturation or the content hemoglobin of reticulocytes, better than doing so by ferritin alone, as the later can be an acute phase reactant. Infection and inflammation gives poor response to ESAs and even to iron, and maybe we don't use iron in cases of active infection. And this causes, again, ESA hyporesponsiveness. Definitely chronic blood loss, and I would advise that you would test for fecal occult blood in stool for every single patient who do not respond enough to ESA, specifically if he is receiving iron. And this can occur from the multiple heparin dosage and other anticoagulants that our patients are commonly using. Hyperparathyroidism, specifically if it goes for the tertiary level of hyperparathyroidism with the osteitis fibrosa cystica, this causes ESA hyporesponsiveness again. And this is the definition of ESA hyporesponsiveness. It's a significant increase in ESA dose requirements to maintain hemoglobin, or a significant decrease in hemoglobin at a constant ESA dose. So either you need to give a mega doses of ESA, or if you kept the ESA at the proper dose, you are losing hemoglobin. This should be considered as ESA hyporesponsiveness. On the other hand, a failure to increase initially of the hemoglobin to greater than 11 grams per deciliter, despite having ESA of a dose of greater than 500 international units per kilogram per week, which is actually a mega dose. As you might know, that we use almost 1/10 of this dose to start with. But if you go to that much and you cannot reach the target hemoglobin, so this is ESA hyporesponsiveness. And this is how you assess. You would look for the reticulocyte index, the transferrin saturation, and the serum ferritin. If there is increased reticulocyte index, increased serum bilirubin, and LDH, you might look for some causes of hemolysis. Look for autoimmune hemolytic anemia, for G6PD, for sickle cell, or even sepsis that can cause hemolysis. If no evidence, look for blood loss, either in the hemodialysis apparatus and lines and filter, or in the gastrointestinal tract by fecal occult blood, or in excess menstrual cycle in females, or even during surgeries or any minor procedures. On the other hand, if the retic index is okay, look for the morphology of the RBCs. If they are normochromic, so if it's rapid fall in hemoglobin with pancytopenia, look for causes that can lead to bone marrow suppression, starting from hematological diseases to chemotherapy and other medicines, or even viral infection like CMV or HIV. If it is severe anemia, look for androgen deficiency or pure red cell aplasia. If there is no rapid fall in hemoglobin, gradual fall, look for drugs like ARBs or hyperparathyroidism, vitamin D deficiency. If there is increase in ferritin and CRB, so this is inflammatory or infection. If there is a macrocytosis, definitely you have to look for vitamin B deficiency and folate deficiency, or alcoholism. With microcytosis, you have to exclude toxicity by aluminum, lead, copper occurred due to poor dialysis water quality, or additional drugs like aluminum binding agents, and hypothyroidism should be taken in consideration in those patients as well. How to manage a patient with a poor ESA responsiveness? First, you have to check for compliance and for the proper dosage to relative to the body weight of the patient. Second, look for the reticulocyte count and look for the algorithm that we have just mentioned earlier. Measure vitamin B12 and folate, specifically if there is a macrocytic type of anemia. Measure the iron status using the transferrin saturation or the chromatin hemoglobin content of reticulocytes. Measure the PTH, specifically the intact PTH, and best to do that in the early morning between 8 and 10 a.m. And measure the markers of inflammation or infection like the CRP and ferritin. Look for the dialysis dose and evidence of poor dialysis quality. Look for the drug history of the patient and whether it's using ACE, ARBs, or other drugs that can cause anemia or blood loss. And lastly, you can go for bone marrow biopsy, specifically if you have more than one type of blood cell deficiencies like bicytopenia or pancytopenia. Iron deficiency is an important issue because it's very prevalent in our patient and it's not simple issue. Iron is needed to complete the armamentarium in the management of anemia in CKD patients, and types of iron deficiency in our patient can be absolute iron deficiency, which is a real deficiency in the iron storage and iron content of the RBCs, and functional iron deficiency, that's to say iron is relatively deficient due to the excess need by the erythropoietin stimulating agents, or an inflammatory block that prevents good utilization of iron. In absolute iron deficiency, this could be due to poor oral intake, food interaction, or poor gastrointestinal absorption. That's why in those patients with late stages of CKD, oral iron might not be the solution to iron deficiency, increase losses like with local GIT losses or repeated phlebotomies or heparin from dialysis causing losses. In functional iron deficiency, there is insufficient mobilization from the storage, and this does not support adequate erythropoiesis mediated by the S. Inflammatory block, there is refractory anemia due to underlying inflammatory state. And the magic word here is hepcidin, because this is the mediator of this inflammatory block of utilization of iron. And these are the parameters that we use to figure out the situation for the anemia regarding the iron markers. The ferritin in absolute iron deficiency is very low, below 20. In functional, it's normal. And in inflammatory, ferritin is increased far beyond 500 even. The transferrin saturation absolute iron deficiency is below 20. In functional, it's 20 or less. In inflammatory, again, it's below 20. Just minding you that the target TSAT, transferrin saturation in our patient, is not 16, as in normal population, it's usually above 20, 22, and we target 28, and in some literature, maybe up to 30, specifically with patients on dialysis who are being treated by S's. The response to iron therapy is good in absolute iron deficiency and in functional, but it is not in inflammatory situation. That's why iron should not be used in this situation. It's only would increase the ferritin, which is an inflammatory marker. When you give iron to a functional iron deficient patient, the ESA dose would decrease. In inflammatory block, there would no be effects, as well as the same with IV weekly iron dose. And this is how we define iron deficiency by markers. As we said, the hypochromic reticulocyte red blood cells less than 6% is an evidence of iron deficiency. The reticulocyte hemoglobin content less than 29 picogram is an indicator of iron deficiency, and a serum ferritin of less than 500 and the TSAT of less than 22 are definitely indicator of iron deficiency. And you have to note that these are not to be used with thalassemia or thalassemia traits because they would be increased in this situation. And these are the indication for iron therapy according to the KDIGO and European best practice guidelines, and the KDUKI and the Keraie Australian, Canadian, and British guidelines according to the level of transferrin saturation and ferritin. As you see here, we mentioned the figure of 500 for the ferritin and 30% for the transferrin saturation. Again, for the British, who are more conservative, the serum ferritin of less than 200 and the transferrin saturation of less than 20%, unless the ferritin is more than 800, which is the situation in which you have a definite a case of inflammatory situation. That's why you should not consider this as an iron deficiency state. The severity of iron deficiency, the need and response to oral iron, and the stage of CKD in a non-dialysis patient is the main issue of the type of iron supplementation. Yes, you can give oral iron, maybe up to early stage 4 CKD, although the response in stage 4 might not be that much good, but it can help you to avoid cannulation and loss of potential vascular access that can be used in the late. As you know, iron can be very corrosive and can be very traumatic to the tissue if extravasation occurs. Definitely when a patient is on dialysis, there is no need to give the patient oral iron because he had access for his venous circulation many times a week. So IV iron can be given at this situation. This is the recommendation with different, again, guidelines of how to give iron, whether oral or IV or using the transferrin saturation and using the serum ferritin to guide your practice, as we mentioned earlier. Now we're going to move to another issue in the management of anemia, which is the ESAs and the erythropoietin stimulating agents. As you all know, there have been a lot since the first generation of epoietin alpha early in the late 80s in the previous century, and going up to epoietin theta and zeta and many biosimilars that have been there, and the Mircera, the long-acting form, the recombinant form. All these have been used, and some of them have been authorized in the States and in the European countries and in other regions around the world. But to go through the management of anemia, actually, we have to look both ways, in the erythropoietin-dependent pathway and in the iron-dependent pathway. And in the erythropoietin-dependent pathway, it is not only EPO, as it has been previously postulated, and for decades, we have been only in the box of EPO till thinking outside the box started to appear. Here, there are non-EPO-producing interstitial cells, and there is what we call the hypoxia-inducible factor with the hydroxylases of the BHDs that causes early hydroxylation of these enzyme and deactivation. And this is linked to the von Hippel-Lindau complex, and preserving this hypoxia-inducible factor by blocking the hydroxylation and the PIH for this entity of the molecule can cause persistence of stimulation to produce better outcome regarding correction of the anemia in another pathway. And the hypoxia-inducible factor, as have been observed in certain groups, ethnic groups who always have good or higher level of hemoglobin, maybe even higher than normal hemoglobin, as we will see later, was the clue for starting targeting these molecules by pharmacological inactivation of this inactivator to the hypoxia-inducible factor to keep them working and thus having better outcome for hemoglobin level. It's actually not only managing erythropoietin receptor and the JAK2 pathway related to this, it always addresses the STAT5 and the, again, EPO receptors, which will, as you know, as you will see downstream, would cause multiple effects than simple preserving EPO. So the HIF stabilizer are proximal to EPO receptor actually, and this is the first step. Targeting EPO receptors themselves by epomimetic or epofusion protein or even epogene therapy have been proposed, although nothing, also so far, none of these have been successful. And distal to EPO receptor is the activin traps, which have been there for a time then of no value so far. And these are the effects of HIF stabilizer and the pathway of action, hypoxia-inducible factor, going through the pathway of PHD inhibitor for the treatment of anemia in CKD. As you can see, that this hypoxia-inducible factor alpha would cause binding to the hypoxia-inducible factor beta, and this would lead to nuclear activation and transcription. And the main issue is the very rapid hydrolysis of this HIF alpha molecule by the porolyl hydroxylase, dehydrogenase, and the inhibitor of this molecule would preserve the HIF alpha to work in a continuous model that continually increase the hemoglobin response to this. And these are many, many compounds. So far, more than 100 different compounds have been developed for the stabilization of the HIF through the inhibition of the PHD by competitive pathway. What these PHD inhibitors do, they preserve the HIF, and preserving the HIF will promote endogenous erythropoiesis, and this complete erythropoiesis would be mediated by increasing erythropoietin level, keeping them at higher level, increasing aporeceptor activity, decreasing hepcidin that we've mentioned earlier as a blockade of inflammatory iron utilization, and increasing DMT1, which is the divalent metal transporter, and increasing the DCYT, which is the duodenal cytochrome B, and increasing transferrin receptor, the soluble one, and ceruloplasmin. All these actions eventually will lead to better erythropoiesis and increase in the RBC's volume and number. Not only erythropoietin or erythropoiesis pathway, but also iron metabolism. The iron metabolism through stabilization of the HIF2 would go on the duodenal cytochrome B, and this would act again on the DMT1 and the ferropoietin here, and the hepcidin effect on the ferroportin, and this would lead to better utilization of iron, both in the cytochrome, in the hematopoietic organs, in the liver, and better utilization with the bone marrow under the effect of EPO to produce RBCs. So better utilization of iron, blockade of the hepcidin, increasing the ferroportin, and causing better iron metabolism in the RBCs is again mediated by the HIF PHDI or HIF stabilizer agents. Hepcidin is another story. The PHD inhibitor trials shown decrease in plasma hepcidin. It's unclear to which extent it is independent of EPO. So it can occur even independently of EPO stimulation. And definitely, as we've said earlier, this would increase iron utilization through the decrease of this hepcidin and the mediation of ferroportin. And in those patients treated with the PHD inhibitor, you would find that the EPO level would almost mimic as you can see, the level of those treated with IV EPO. Much lower EPO level compared to IV injection of epoetin alpha, possibly increased sensitivity toward the PHD inhibitor induced EPO. Head-to-head comparison with similar plasma EPO level has not been performed. So this is contemporary from different trials. That's to say the mediation could be by increased sensitivity and better responsiveness to the same doses of EPO. And this recent visual abstract about the effect of the prolyl hydroxylase inhibitor, the HIF stabilizer, in the treatment of anemia by oral administration of these HIF prolyl hydroxylase inhibitor causes in both non-dialysis CKD patient and dialysis incident and prevalent CKD patient, both in correction or maintenance of hemoglobin, measuring the iron parameters, the need for IV iron use, the need for blood transfusion, the serum cholesterol level, and the overall safety, and the clinical effect using the stimulation of endogenous EPO, the promotion of iron mobilization utilization, the efficacy in CKD patient with inflammatory situation as evidenced by increased CRP, and the hard outcome by the impact on the major cardiovascular events, and the extent of delay of renal disease progression in the pre-dialysis population, and other safety considerations. And the conclusion of the trial was that the prolyl hydroxylase inhibitor, HIF stabilizer, demonstrated efficacy in treating anemia of CKD. The preliminary data suggests that they have effect beyond erythropoiesis and iron metabolism, impacting positively cardiovascular safety, and the long-term safety need to be established in extended trials and post-marketing analysis. These are the agents that are currently either in marketing or in phase 3 preliminary or completed phase 2 trials: the roxadustat, the vadadustat, and the daprodustat, and the molidustat. And these are the agents that are actually in the pipelines, with the exception of the roxadustat that is already being marketed in different countries around the globe. These are the summaries of the trials. We've mentioned what's related to them. And maybe I'm not going to go through the particular of each one of them, but this very busy slide is just to show the complexity of manipulating the PIH or the PHD inhibitor using the HIF stabilizer, both along the line of anemia and along the line of other targets that are to be evaluated in the future. And this is the benefit versus risks. We've mentioned most of the benefit already. The concern were mainly about hepatotoxicity, which was not proven to be very concerning in most of the trials. Hypoxic sensitive genes like the VEGF, tumor growth, and proliferative diabetic retinopathy was a concern, need to be validated in the longer trials. Enhanced growth of renal cysts, specifically in patients with cystic kidney diseases. Some unexpected effects that's not known yet, and the long-term studies that is to be awaited, and the bill burden as it is an oral drug that might cause some GIT concerns and discomforts. I think for the concern of time, we'll stop here, as other agents targeting aporeceptors or distal to aporeceptors like the traps have not proven successful yet in most of the pipelines, and nothing of these is of clinical benefit. So we'll stop here, and hopefully that we can be using the HIF stabilizer in the near future in our armamentarium in managing anemia of CKD patients. Thanks for your time, and hope to see you soon. Assalamu alaikum wa rahmatullahi wa barakatuh.